Dr. Sagaro does not require any kind of introduction to this audience. I myself, probably if I am fortunate enough that I have been working with him for about 7 years, I feel it's a fortune that I have been learning each and every day knowledge from his vast experience. And he's the one man who has seen when he makes rounds, he teaches students. When nobody is there, he calls me and teaches. Even today, even he's one of his colleagues. So this man has a passion to teach and has a vast experience, and he is more up to date, I can say, than many persons in India and probably abroad. I'm quite proud to introduce him, and I know Dr. Raji for many years. A very industrious guy and very knowledgeable and an aggressive interventionist, and he's now, for a change, he's talking about prevention and political. Thank you very much.
So, good evening. Definitely be an impetus for them to become scientists in the later part of the life. Okay, we should thank Rajiv Modi for choosing a nice term, I think. Then, secondly, we should thank, I am speaking in front of my teacher. I was the first student of Dr. Dasagarao at Durgabai Deshmukh Hospital. Okay, and he has been inspiring always. And it's great to have an association with him. And speaking in front of him is just like speaking in front of a giant and knowledgeable person. He, at this age, also reads a lot. I think I don't read as much as he reads. And I'm very safe when he is a chairperson, because if I am unable to answer the questions, he is there to answer that. Then we should go to our keynote address speaker, Dr. Nick's points. We'll just revise a few of them. You've just seen the difference. He works in London, we are in India. The most important difference is the economic backgrounds of both the countries. He is using the latest subcutaneous pacemakers, renal denervations. All these things are still in a very primitive state in India. We do have few schemes which the government has enhanced and probably making the medical things reach the common people. That is an Arogyasri scheme running in this state of ours. It is really benefiting the poor, and we do need economical drugs to sustain the scheme apart from the economical stents what we are using and economical surgical techniques. Then second thing what we have to emphasize is the load what India has. He has emphasized in one of his slides. 17% of the world population catering 60% of the disease. So see the difference what we have. Among the world population, we are only 17%, but we cater 60% of the cardiovascular disease. So a huge burden in India we have about the disease. Second, most of them are occurring, three important factors which have come out of Dr. Salim Yusuf's study, that is the CADI study. It occurs a decade earlier than the West, what he nicely has emphasized. We are getting cardiovascular disease at 55, whereas in US it is 65, in UK it is 75. Then second, the Indians are having increased triglyceride levels. Third, the diffuse nature of the disease makes it difficult to treat. Whereas in the West, the disease is more focal, single stent probably helps them out. The size of coronary artery, what we have seen in our last 15 to 18 years of our intervention practice, the diameter of coronary artery in the West is about 3.5 millimeters, whereas in India it's about 0.5 less. So we have an average 2.75 to 3.2. So as we go down the distal end of the coronary artery, it shortens to less than 2.5. The most important is the diffuse nature. So stenting becomes tougher in such cases, diffuse nature of the disease. Whereas in West, there are focal lesions, the diameter of the artery is bigger, so the rate of restenosis is slightly less. Then third most important thing is our risk factor, we have increased triglycerides. Then lastly, most important, the economic constraints what we have. If you go through a few studies which I will show, most of our patients stop using drug within 1 or 2 months of the event because of financial constraints. So to emphasize and to make them realize It is our first duty as a doctor that few drugs are to be used lifelong, and for drug to be used lifelong, the most important thing is it should be economical. And in such endeavor, we should congratulate Cadila Pharmaceuticals for making an innovation. Till now, we have copied most of the drugs from the West and they come to East. But this is the first drug which is going from East to the West. It has been documented in Harrison's textbook of medicine, and we should congratulate for such a patient follow-up of the drug development which Cadila has not given up. And now, with the advent of this, we will have limitations of polypill. I am not telling that it is the answer, but it is one of the answers in our situation, because it is a fixed drug combination. So to titrate the drug, probably we might have to add, but even if 30 to 50% of the patients fit into this dosage combination what they have chosen in polycap, it will do a lot good to Indians. There will be side effects of individual drugs which will make it to withdraw. But even if 70 to 80% tolerate the drug in the given dosages, it is a great achievement which Cadila will be doing for Indian economy and for increasing the compliance of the drug. With these few words, we will start with the presentation of polycap. So the challenges, already a lot of them have been discussed by Dr. Nick, and we'll just run through them. The current challenges are the changing epidemiology. What I mean by epidemiology is, as he has shown, childhood obesity is increasing. It occurs at a younger age in Indians. So it emphasizes the need for early detection of risk factors, for control of risk factors, and then lastly for the solutions, implementation of guidelines and the polypill in the last. Early detection of cardiovascular risk factors. Now, it's a cluster of cardiovascular risk factors which lead to the various cardiovascular manifestations and ultimately the myocardial infarction. Most important being hypertension, obesity, low HDL, as very well emphasized by Dr. Nick, high LDL-C, and total cholesterol. How to control? Despite our best efforts, the blood pressure remains uncontrolled. Inadequate control of blood pressure in spite of regular visit to the doctor. If you critically analyze our data, about 50% do not have treatment changed despite persistently elevated BP. They say we will use the same drug. They continue to use the same drug, patients. They are very reluctant for change, higher dosage or addition of drugs. Despite multiple guidelines, elevated blood pressure until more than 150 is untreated in most of the populations. Only 60% have their systolic blood pressure value reduced to less than 140. Now what does the guidelines say? There was a study called PURE. It was an epidemiological survey study published in Lancet, and we will be surprised by the usage of various drugs and very highly underused. This drug study shows underuse of low-cost medicines for secondary prevention. Only 19.5% prescriptions had ACE or ARB. Only 14% had statins. Only 17% had beta blockers, and 25% had antiplatelet drugs. So one of the drugs will be definitely lacking in our prescription because of the cost factors, because of the side effect profile. There is another study called Eureka study, European study on cardiovascular risk prevention and management in usual daily practice. It was carried out in 12 European countries between May 2009 and January 2010 to evaluate physicians' attitude to risk factor control. Very important. We can analyze ourselves in this situation. How many of us follow guidelines? In European, there are few guidelines for cardiovascular diseases, few guidelines for hypertension. There are ATP guidelines for cholesterol management, JNC7 for hypertension management, local guidelines and other guidelines. You will is the guidelines. In Germany, it was slightly higher, 60%, but general European average, where the doctor is supposed to practice in a very ethical way, very systematic way, you can see it's only 60%. This is for cardiovascular prevention. For hypertension, just see, only 45% of German doctors and 28% of European doctors followed the guidelines. You see for cholesterol, so low, only 9 and 8% respectively. You see the JNC7, though it is obsolete now, Only 5% and 9% followed these guidelines and maintained those levels. So what does this say? Despite guidelines, we have our own way of treating the patients, and it is not the total answer for managing a patient. Then what is secondary? This was the doctor's part of it. Now see the compliance of the patient. A premier study was done, which was a secondary prevention study. You can just see 1/3 of the patients discontinued treatment within 1 month. This is very important. Continuing all 3 medications, only 66%. Discontinued use of all medications, 12%. Discontinued 2 medication or 1 medication depending on the discretion. He does not know which medicine to discontinue, but he'll just take 1. 3 to 17%. So all this say that it is not easy to motivate a patient to take all the drugs every day. So came the era of fixed drug combinations, which was popularized first in India, but now well accepted in the America and Europe. Effects of fixed drug combination strategies improve the adherence and apply to better control of patients. The Umpire randomized clinical trial proved this. It was a 2004 patient established cardiovascular risk or disease were enrolled between July 2010 and July 11 in India and Europe. It came with an objective to assess the FDC delivery of aspirin, statin, antihypertensive versus usual care for long-term medication. The conclusions are, if you use polypill, the adherence improves to 77% compared to 23% in the usual care. Generally, patients do forget 1 or 2 medicines definitely. So by using polypill, your compliance, your adherence to FDC will improve definitely. It's a 3-fold increase in the compliance. Then came the innovative idea with this background, the idea of polycap. It was a very innovative idea. The drugs chosen were with definite indications, and this is the bioavailability profile of polycap drugs. It's a drug consisting of aspirin, then it is a drug consisting of simvastatin, and then atenolol and hydrochlorothiazide. So you can just see, they have compared the bioavailability compared to the international brands in polycap. The baby aspirin, antiplatelet 100 milligrams, it was compared to the international brand baby aspirin, and you see the bioavailability, it is almost the same. 27,191 AUC unit as it is called. In baby aspirin it was 27,773. So it's comparable. You see the ramipril 5 milligrams. In polycap you have 14.8 versus Altes, the international brand, 13.3. Simvastatin in 20 milligrams, it's an LDL lowering drug. It was compared to Zocor, so 25.7 versus 32.6. Then atenolol was the antihypertensive polycap. It was 3,206 versus 3,374 AUC in the international brand Tenormin. Hydrochlorothiazide 626 versus microzide 668. So with the combination also, the company has maintained the bioavailability. There is no pharmacokinetic interactions. 92% patients completed the trial, very important. Polycap preserved the individual pharmacokinetic drug of each of the drugs. It was published as a TIP study, Indian Polycap study, championed by Cadila Pharma and Salim Yusuf, published in Lancet 2009, April issue. The key results were, it helped in better control of blood pressure as shown in the diagram. When you use one drug, it lowered by 2.2, and when you use 2 drugs, 4 systolic versus 3 diastolic. If you use 3, it is 6/9, but when you use a polycap, the reduction in blood pressure is 7/5. It reduced the heart rate, LDL level and platelet aggregation. Effects were similar to individual drug regimes, and most important, 85% of the patients completed the trial in the polycap arm. So polycap definitely reduced multiple risk factors with an improved compliance. That was the bottom line, which is to be underlined. In compliance is very important. The benefits of polypill are, there is a significant CV reduction, improved adherence and compliance, reduced side effects and cost saving. Therefore, widespread global interests among physicians, patients and policymakers did instigate the use of polypill. Who can benefit from polypill? They are the patients with established cardiovascular disease, that is patients with heart disease and stroke, with or without hypertension, with or without dyslipidemia. Because, as Dr. Nick has already told, diabetes is an equivalent to coronary artery disease. So it should be treated, all the drugs what we use for CAD management should be used in a diabetic patient. It can be used in patients with hypertension and dyslipidemia. Large number of patients can benefit. CV risk management, challenges and solutions, summarizing the whole thing. Coronary artery disease and stroke are the biggest killers in the society. Hypertension, dyslipidemia are major risk factors. Risk factors require early recognition and effective control. New guidelines recommend polypill for an effective control of multiple risk factors. Polycap is effective, well-tolerated solution for a changing epidemiology. Thank you.
I think it's a very important question, and I was just raising the issue, Dr. Bala. I think for the sake of scientific clarity, this concept of multiple drugs being used was a postulation proposed by two British doctors, Wald and Law. They said that if you can control the 4 factors, you will be reducing the cardiovascular disease by 80%. That is still a concept. It has never been proved so far. Having said that, there are issues that if 4 individual drugs can do their job, a single pill containing all the 4 drugs should be able to do it. So it is still 4 drugs equals to 1 capsule and 1 capsule equals to 4 drugs. It is still a postulation. No study has shown that as of today, that polycap administration has resulted in reduction of the vascular events or reduction in morbidity or mortality. But it is fair to expect that this might happen. Now, having said that, my personal experience has been that various reasons have been given for not taking or for poor compliance. And the audience are given to think that Indians in particular are very bad in following the doctor's prescription. If you see the Pew study, everybody or all the people in every country are more or less the same. If our compliance is about 10%, their compliance is no better than 20 or 25% maximum. And this applies both to costly drugs as well as simple drug as a simple drug like aspirin. My personal experience I will narrate to you because we have a situation in this state wherein we have got this Arabistry scheme where the people are given medicines after an intervention, either angioplasty or surgery, free of cost for 1 year. And I was one of the few in our department who says that giving so many drugs, let's give only 1 drug, that is polycap. And my experience has been in these patients has been that 90% of them continue to take the drug for whatever reason. One is it is given free. 2, they are told that this drug is important at least for the first 1 year. They have to take it. And Arabistry system has got a very interesting and a very important scheme which probably no other country has. That is, they have field workers from Arabistry department which will verify whether they are taking the drugs or not. And this kind of a system is never existent, to the best of my knowledge, either in the West or in any of the countries. So they are made sure that the patients continue to take the drugs, and the patient doesn't turn up. They are requested to turn up to have a checkup, followed by the drug being used. Now, what happens after 1 year, we are not very sure, because after 1 year the patient has to buy. So it is almost equivalent to a general population. But to the best of my knowledge, under my care, we have seen approximately about 10% of my patients coming back saying poor tolerance. After I started taking the drug, I'm getting this, I'm getting that. Some are hypotensive, some are having cough, all the undesirable side effects. Each component of the drug, of the combination causing some trouble or the other. And I'm forced to stop the polycap and then change over to some other alternatives. So my suggestion to the Cadila company is that if you're going to have this program to be successful, you need to improve your innovation further. Saying that polycap 1 and polycap 2 or whatever number you want to do it, so that it will be useful for more number of people and the compliance of the polycap will be much better. That has been my suggestion. It's a good drug, it's quite effective drug, and my policy has been after CABG and after intervention, I give this polycap and then give additional thienopyridine drug as a part of dual antiplatelet therapy, because polycap does not contain thienopyridine. Polycap contains only aspirin as an antiplatelet drug. And it has been quite effective. And although people have been taking only, have been provided with the bare metal stand, it does work. It does work very well. And nobody has come back with any serious untoward complications. Minor undesirable side effects are there, and they do come back and we do change them. But that percentage is only 10%. OSA, yes, sure. But this is OSA has been a new risk factors. But it's worth noting that although obstructive sleep apnea is purported to be one of the risk factors, nobody has shown till now that treating OSA certainly decreases the events. That's one of the biggest factors. With all the complications of OSA, forget only about even MI. When hypertension has been said, pulmonary hypertension has been said, but no study has shown till now that treating obstructive sleep apnea by whatever means, both by devices as well as by surgery, it has not changed the occurrence of the disease further. So we still have a missing link in that one. What is the mechanism of production and what is the basis and why it doesn't reduce it? So we are not very sure. Talking about these innovations and talking about these factors, one of my visiting colleagues from UK, he has presented a data that renal denervation therapy as a part of treatment of hypertension. Probably by oversight he has not shown the final data where it is a study done from US, double-blind study, wherein half the people underwent a sham surgery. That means they only had renal angiogram but no angioplasty or no renal denervation has been done. And then they have shown that renal denervation is no better than a sham. So we still have got a long way to go as far as the renal denervation therapy as a part of a treatment of hypertension. There are still a lot of studies are going on, why it is failing and what are the causes, whether we can do anything better. Innovations in concepts, innovation in technology, innovations of additional drugs to be added to these patients, all these things are going on. So as of today, renal denervation therapy is still a concept, it is still in evolution. Probably we hope that it may, fructify and probably maybe